Hey guys, Mike Verkest from the Second Shift Podcast here to talk to you about PIASE. Back in 1996, I had 2 certifications to manage, my state license and national registry. That was it. Fast forward 20-some years later, and what I would give to have just 2. Between my advanced certifications, ACLS, PALS, PHTLS, you name it, I'm looking at upwards of 10 certifications to manage. That's where PIASE saves my bacon. I simply add my certs, expiration dates, and bam, no more surprises. Take pictures front and back and share those credentials with whoever needs them. With the touch of a button, it's easy. Go to the App Store now for your device and search for PIASE, P-I-A-C-E-T, PIASE. Do it today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today we're going to do round 3 of a podcast that we've tried to record a few times. I'm here with my good buddy from Enloe in Chico, California, Mike Herman. How you doing, buddy?
Oh, fantastic. Good morning. Yeah, round 3, but the first time you'll actually hear it, it's our round 3. Because what went on those first 2 rounds there, Eric?
Well, we were getting some little reverb somewhere, and so, yeah, we were getting kind of stepped on. But I think we got it figured out. I hope.
Yeah, well, the jokes are the same, the questions are the same, so we should have it pretty dialed by now. Just make sure you laugh.
So this podcast is a podcast that you recommended that we do. You had some questions after reading the book, and I'll let you kind of introduce that and introduce yourself. And so I thought, why not do a podcast where we try to put out 5 top questions that I know many people have, and so you're going to kind of interview me based on your curiosity and questions, and then I'll try to answer them as best I can.
Yeah, exactly. Well, first, thank you for having me on. My name's Mike. I work at Enloe Medical Center in Chico, California. Been a nurse there the last 8 years, and I've been flying for Enloe Flight Care for the last 4 of those. I've had somewhat of an obsession with mechanical ventilation for a few years now, and I think it all started when my buddy Scheller and I had a very sick post-op patient. We took this lady from a rural OR down to a tertiary hospital, and we're just both at a total loss of managing her vent, and we both realized then, like, holy cow, we can really kill somebody with this machine. So since then, I've eaten up every word you've said and written, and Jenny, our chief flight nurse, very supportive of our education and progression as clinicians, so got to have you and Mike out here for a vent course, which was awesome. Definitely still very much a novice vent nerd, and have a handful of questions I wanted to come on and ask, and hopefully questions that other people might have as well, and so that'll be helpful for them. But little disclaimer, we use the LTV 1200. It's all I'm familiar with, so my terminology will be based off that. If there's other terms for the Hamilton or other vents, feel free to clarify. But yeah, just a novice trying to wrap my head around some of these concepts, so please, if anything dumb comes out there, misworded, feel free to correct me.
So why don't we start in with question number 1?
Yeah, so I wanted to go big right off the bat and start with the classic volume versus pressure debate. For those of you who weren't at Fast 18, which you totally missed out, I recommend Fast 19 for sure. Tyler and Eric had a vent battle royale. It was hilarious. And Eric, I came in there on your side. We had these shirts made supporting you. Then Tyler comes up there with his medium shirt, perfectly sculpted hair, freshly manicured, I'm pretty sure. I mean, come on, Eric, what are we supposed to do? Stay on your side?
Well, number 1, that was like probably a whole case of gel. And number 2, I didn't forget my lines.
And rumor has there was some maybe an inside job on that one, but you guys missed out if you weren't there. Yeah, so obviously there's no definitive evidence on this, or this wouldn't even be a question, but in your critical review course, rumor has it that you say all patients should be in pressure, and even in your book you say, and I quote, pressure ventilation is the best manner of delivery for many reasons. So Eric, my first question to you is, should all patients be in pressure control ventilation, yes or no?
So this is, as you said so perfectly, there's no true evidence saying that volume versus pressure, one is better than the other one. I think when you look at number one, you have to look at our equipment. You have to look at the patient overall, and I think it's more of a preference. And so here's my thoughts and my rationale. I think number one, all patients, if they're at least going to get a tidal volume of 50 mils, and I say that because most mechanical ventilators, if it's a volume ventilator, that's the lowest tidal volume you can actually put on that patient. So if they're going to be greater than 50 mils, they all have to start out in volume. And the reason why you do that is you check a plateau pressure. So you trend that plateau pressure, see what it is. And the reason why I really started moving more to pressure ventilation was early on I realized that any pediatric patient that's going to need a tidal volume less than 50 mils, and we'll get into kind of some other thoughts on that, I didn't want to get into a situation where I didn't understand pressure ventilation. I didn't want to feel uncomfortable and fumble through that on a sick kid. So I really forced myself on stable adult patients to move to pressure and really get comfortable with pressure control ventilation. Now, with that being said, I think I found that number one, patients seem to do a little better. I saw some improvements in compliance. I saw that they needed less sedation. It's not a perfect way to deliver a breath, but there's definitely some advantages, I feel, in giving a volume breath in comparison.
So you said starting with volume to check a plateau and then switching to pressure. What if your PIPs are fine, your plateau's fine on volume, the patient's comfortable? Do you still switch, or are you just starting to see what your baseline plateau is and then always switching?
Yeah, so again, kind of two thought processes. Number one, I just wanted to become comfortable in that way of delivering a breath, and I think the teaching-wise, the most anxiety that I see with clinicians trying to apply pressure control ventilation is that you don't actually have a physical tidal volume that you set at the ventilator, and that makes them very uncomfortable. That's very confusing. And so you have to monitor the exhale tidal volume and target that exhale tidal volume to match what your tidal volume is based on ideal body weight, and then you multiply that by that 6 to 8 mils per kilo. And so I just wanted to make sure that I was comfortable with that. Does that mean that all patients need to move to pressure control ventilation? Absolutely not. I think that there's some that should, and some that are absolutely fine in volume.
Which your point you just brought up, about needing to monitor it, just kind of comes into the disadvantage of the pressure control, right? Where we have to constantly be monitoring for that our minute ventilation, as it can be so variable with changes in compliance and whatnot. So for me, you mentioned comfort, patient comfort. For these short flights that we have, a half hour long flights, I feel like giving them a little more sedation and analgesia, and then having them on volume, where I can get a consistent minute ventilation, is more advantageous to me than putting them in a mode where I have to be more, or a delivery variable where I have to be more attuned to what's going on. Not that I don't pay attention to the vent, but things can happen pretty quickly with compliance, as things improve or get worse, and volumes can change so quickly that the comfort aspect of it, I feel like I can treat with medication. If we have a sick patient, we're doing all sorts of drips, or it's weather, or it's dark, whatever. We might not see changes right away on our vent as, VTEs decrease or increase. I just get kind of concerned that I might miss that, my tidal volumes have dropped, 50% even. And I know we do have our monitor right in front of us, and, we'll see a change in our end tidal probably before we notice it on the vent, honestly, because the monitor is easier to see. But especially, some of these patients that we can keep comfortable with meds, I just not sure if their PIPs are good and their plats are good, if it's worth the risk of the, such a variable minute ventilation. What do you think about that?
Here's my thought process in the helicopter. I think, no matter what, you're in a helmet, you got a loud rotor system, you have kind of noise canceling helmets out there now. And so number one, you're never going to hear an alarm. And so when we monitor volume, we monitor pressures, PIP and P-plat. When we're monitoring patients in pressure, we're monitoring exhale tidal volumes. You're setting a pressure, you're setting a safe PIP, knowing the aspects of PIP versus P-plat, that your PIP is always going to be the highest of pressures. As long as you're setting that PIP at 35 or less, you know that you're in a safe zone for that plateau pressure. So my thoughts are, number one, and I want to be very careful in saying this, I think in a lot of cases you could almost shut off your low minute ventilation alarms or certain alarms, because number one, unless you're visually looking at them, you're not going to hear them. And so I think it gives us a false sense of, the ventilator is going to notify us if we have a high pressure, and that's completely different. And that's where there's a lot of differences in the transport environment than at the bedside, where you're going to hear those things. So my mindset is that any time a patient's on the ventilator, you need to have one clinician focused on that ventilator. It's got to be, maybe you're not visually on it constantly, but somebody has to be constantly watching that. So I don't really use that as an excuse. I think that's unrealistic, and I think somebody has to always be focusing on that ventilator. And whether you're in volume or pressure, I think that overall, when you look at the two, I think you get a lot more advantages in pressure ventilation. You get a decelerating flow pattern. You decrease the work of breathing because of that decelerating flow pattern, and the patient's inspiratory flow is much greater. You get this longer overall recruitment time based on that decelerating inspiratory flow. So where that peak pressure, let's say we set a starting pressure of 20, that peak pressure is met, well, that deceleration of that waveform up into the point where exhalation starts, all those distal and posterior airways are now being recruited, where you don't have that with volume.
Right. So I see that being an advantage for some of our sicker patients with shunt. What about just your standard, trauma, isolated head injury? You've intubated them, they've gotten fentanyl, ketamine, rock, PIP's 18, Plat's 16, and Title's 35. And you want that consistent minute ventilation to keep them at that 35, so you don't, accidentally overshoot or undershoot their minute ventilation while you're, loading or doing other stuff. With something that like a head injury where you're concerned, about their, ICPs, I think that's one instance where volume would be preferable. What do you think about that as an example?
So I think I don't think there's ever a perfect example. I think when you look at a trauma patient, and this has always been a frustrating aspect to managing these patients, is do we truly know how sick they truly are? How much are they truly feeling? We may think that we're sedating them and treating their pain, but do we truly, truly know what we're doing for them? If we have somebody that's a multi-systems trauma, maybe they do have a traumatic brain injury, what's the number one thing that's going to increase ICP other than the injury? And that's going to be pain. So when I look at the two different modes of breath delivery, again, I go back to pressure. If there's no reason, I guess I look at it from the perspective of what's going to be the most comfortable for the patient. What if these patients are, hemodynamically unstable? I guess I look at both of them and I ask myself, well, why wouldn't you put them in pressure? Like, what are you gonna lose by putting them in pressure? Really, there's one negative to pressure control ventilation, and that is a potential variable minute ventilation. And obviously, because compliance changes, you're never going to have an exact perfect tidal volume. It's going to be variable. But honestly, I have never in 16 years had a patient in pressure and had the minute ventilation so variable where I said, oh my gosh, or had somebody decline so rapidly that I switched them out of that mode. I've never ever had that happen. So I almost think that's it's obviously something we have to watch and be careful of. What I've seen in contrast is I've seen patients having their compliance improve. I've seen where I've had, let's say, an inspiratory pressure of 20, so a PIP of 20, so let's say 15/5, and get an exhale tidal volume of 450, and 30 minutes into the flight, have that exhale tidal volume actually exceed that 450. It may now be 480, 500 on that same PIP. And it's because of that better recruitment, to where you actually have to back down your inspiratory pressure. To me, that's a positive. We're doing better for the patient. So I guess I look at it from, why wouldn't you want to master that manner of delivery to where when you truly, truly need it in the pediatric population, you're extremely confident and comfortable. And that's the mindset I've always taken. If there's no harm, no foul, and it's truly I think a benefit, I truly believe it is a benefit. When we look at outcomes, do we look at 30-day discharge? Is it going to make a difference? Probably not. I mean, there's no evidence, obviously, that clinically supports one over the other one. But when you get that pediatric patient, that's where we really have to understand the volume versus pressure debate. And here, if we go back, and if you don't mind, I'm going to kind of jump into some physiology and how all this works. And if we think about a balloon, and I've used this on other podcasts, you try to blow up a balloon. You pull a balloon out of a package, you're having a party, you go to blow that up. First thing you'll realize is that you have to overcome what's called the critical opening pressure. So it takes a little bit of effort to start inflating that balloon. What you'll have is once you open that balloon up and you start inflating that balloon, that balloon is going to rapidly inflate. And that's based on a compliance problem. So you have no resistance, but you have a balloon that's never been inflated. So you have poor compliance. And so you're going to get this rapid inflation to the point of it stopping. Now there's two things that affect that. Number one, we could increase the pressure or the effort that it takes to blow that balloon up, and we're going to get a little bit more volume. But the way that you use that analogy is to explain that compliance always equals volume. And so pressure ventilation is a compliance-based mode. It's never going to overinflate the lung past what its compliance is allowing. And that's where it really does protect that lung from further potential barotrauma. And you look at driving pressure, and you look at, do we truly know one lung versus the other lung can handle the equal amount of volume? Or is one lung sicker than the other lung, where you're just going to put a big, massive volume in, even if it's lung protective at 6 mils per kilo? Do we know that those lungs can handle that? And all we have is to evaluate people out there, right? We evaluate people out. Yep. What they've realized, though, especially in these really sick lung patients, that PPLAT doesn't get it, right? That they've identified that a driving pressure less than 15 is truly what shows better outcomes. So I think that there's those aspects. Now, as I said, it's not perfect for everybody. Let's take that same balloon. Let's imagine, though, now we actually put a let's say one of those little coffee stir straws into that balloon. We tape it up, and now we have to inflate that balloon through that stir straw. Well, we know the inflation time is our inspiratory time, and you can just visualize we're not going to be able to inflate that balloon. Let's say we had 1 second. Are you going to be able to get any volume into that balloon? And the answer is no. So that is the one type of patient that I'm going to stay away from pressure. Is I'm not going to go pressure in a real lung obstructed patient, somebody that's very, very constricted. Because that's where you're going to start having some problems. Again, you're going to have to do one of two things. If you are in pressure, you're going to have to, greatly increase that inspiratory pressure to actually get enough pressure to inflate that. But if that restriction is so great, you're still not going to get any volume in. And that's where, the advantages of pressure control, of compliance equals volume, is going to be a negative in that case.
Yeah, I mean, just in that case of like an ASDEC or something, where you need your PIPs your PIPs are going to be higher than that 35, 40, maybe 45 or 50, but your plats are still fine. And pressure, you wouldn't know. If you needed that much pressure to get the breath in there, you're not going to know if it's being transmitted to the alveoli. Is that what you're saying, basically? That you need so much pressure to get the volume.
You're not going to have enough time. Yeah.
Just what you were talking about, I gave you this quote last time I saw you from Marino's ICU book, just kind of as an argument for volume. And just sitting here listening you talk about the decelerating flow pattern and not knowing which side of the lung's sicker than the other makes me think more about this. And let me just read you this quote real quick that I sent you. At any given tidal volume, the airway pressures at the end of inspiration are higher during volume control ventilation than during pressure control ventilation. And this is mistakenly perceived as an increased risk for ventilator-induced lung injury. However, the risk of ventilator-induced lung injury is related to the peak alveolar pressure and this pressure is the same during volume control and pressure control at equivalent tidal volumes. Therefore, the higher peak airway pressures during volume controlled ventilation do not increase the risk of alveolar overdistension and ventilator-induced lung injury. So I kind of was using that against you, but then I realized, the key phrase in here is at equivalent tidal volumes, and having that decelerating flow pattern with the pressure control makes it so the alveoli, even at a same peak pressure, are going to see different volumes. Is that right? Am I applying what you just said to that?
Yeah.
Right. So therefore, pressure would be better because it's not going to give the same volume to the same lung unit. It's going to disperse it better.
Yeah. And I agree. And I've actually tried to simulate that, based on that passage. I mean, I think there's so many other variables. You have, the last little topic I want to bring up that's a perfect segue to is mechanical dead space. And where you see mechanical dead space in a volume breath, you don't have it in a pressure breath. And so here's the other, aspect to this debate is when you get into a situation where you have a kid, and we've talked about this before, and I've seen this many, many times, and I've read many charts where this has been basically spelled out. You have, let's say, a child that is got bronchiolitis, RSV. They've got some airway resistance. They've declined to the point where they've intubated that little guy. The patient is, we'll say, 10 kilos. And so based on 6 mils per kilo, they can start with a tidal volume of 60 mils. That puts them inside the range of volume ventilation in these ventilators. So if you're using the LTV 1200, the 1000, the Ravel, for example, 50 mils is the lowest tidal volume and volume you can give. If you're using the Hamilton T1, we got to remember that is a 100% pressure driven ventilator as far as a pressure breath, but it's volume targeted, so it's the same thing. It's just that is always pressure. So that doesn't count. So with a ventilator like the LTV 1200 or the Impact, the NV, any of those ventilators that are volume and pressure driven, in a volume breath, essentially that breath, let's say we're giving this little guy 60 mils out of the ventilator. Well, let's say their PIP is 35. Well, in the circuit, we have expansion of that circuit. That circuit has compliance to it. So when that volume is delivered out of the ventilator, it comes out 60 mils. Well, what happens in that circuit based on the inspiratory pressure is you're going to lose volume. And so for a pediatric circuit, CareFusion uses, I think it's 0.75, so you can just round that up to 1 mil. So 1 mil for every centimeter water of PIP. So if their PIP was 35, you're going to lose 35 mils of dead space in that circuit before you ever reach the Y or the ET tube. So then what you see is you'll see exhale tidal volumes come back of 15, 16, 18. So you're trying to deliver 60. You're only getting back just a fraction. And it's because you're losing the majority of that volume before it ever reaches the patient in mechanical dead space. And that is a big problem. And if you don't understand that, what happens, and I've seen it again, I've read so many charts that have shown this exact type of situation, is they put them on the vent, they notice that there's no chest rise or fall, patient desaturates, they take them off the vent, they start bagging. Once they start bagging, SpO2 improves. And so what they do is they chalk this up as a ventilator that's broken. And it's just a factor of mechanical dead space. You take that same little baby, now you move them to pressure control ventilation. How does that benefit? Well, now we start with that inspiratory pressure. We target our exhale tidal volumes. And what we can do now is we have to understand that we have no mechanical dead space because the flow sensor is at the end of the Y, right before it comes out. And so that's what actually is measuring that pressure. So anything that happens prior to that in the circuit is already accounted for. And so mechanical dead space is not.
Yeah, and that one on our second take of this podcast recording, really, you blew my mind with that. And I remember reading this in your book. I just didn't put it together from your book as you did for me now here and then on our second recording, and just how important that is. And what exactly was happening with that. I knew there's circuit there, but what exactly is happening that lets that be dead space in volume? Kind of where that back pressure of the PIP is just making the plastic expand and losing the volume there. So I just, for some reason, I'm slow. I'm a simple man, Eric. I'm a man nurse. And that one went over my head several times after reading your book, but thanks for explaining that for me.
No, and in the adult population, the adult patient, it's not a big deal. If you have, say, a tidal volume at 500 and their PIP is, 30, well, in an adult circuit, you actually lose more mechanical dead space. It's 2 mils times your PIP, and that's just a really easy number to memorize. It's actually a little bit less than that, but it's a really easy number to memorize. 1 mil for a pediatric circuit, 2 mils for an adult circuit. Multiply that times your PIP, and that's the mechanical dead space in volume. So, if you don't understand mechanical dead space and you have that happen, there's, the other way to deal with that on a pediatric circuit is understand, all right, well, I'm losing 35 mils of mechanical dead space, add that on top of the tidal volume you have set. But what is that going to do? That's going to increase the PIP even more. And so, PIP is a product of multiple variables. Compliance, flow, volume, resistance, all that stuff is put into an algorithm in the ventilator spits that out. So, you're going to get a slightly higher PIP if you do that, and I just think it's better in these kids to just switch to pressure and just, deal with it in that perspective.
And then just lastly on this volume versus pressure thing, 18 years now since ARDSNet released, their lower tidal volume thing, and so how come, if pressure is better for ARDS or patients with this real bad shunt physiology, why are they still saying, or maybe they're not, but why do you still say go down to 4 mLs per kilo before switching to pressure? If it's truly better for ARDS, how come they don't just come out and say start in pressure for them?
Well, again, I think we have to be careful saying one is better from the other. I really want to just make sure that everybody understands that this is just my clinical judgment and experience over 16 years of flying patients, and I just, doesn't mean that volume is bad. I think when you look at now, hospitals are applying standardly PRVC, pressure regulated volume targeted ventilation, which is a pressure volume target, and that's exactly how the Hamilton is utilizing that concept as well. And so I think we know pressure is a better way of delivering a breath. There's lots of alterations. Every ventilator is a little different. There's a lot more options on these hospital ventilators than we have in the transport environment. A lot more combinations.
Yeah.
So.
Yeah. We're getting a Hamilton soon, hopefully, and in the next several years, I'm sure everybody will be switching to something with some sort of decelerating flow pattern for volume. So this will all be irrelevant maybe soon, but good to think about for now anyway, while we still have the LTV here.
Sure.
Okay, well, I guess we can move on off of that if unless you have something else you want to say
I
on
think
that
that's good.
front. Okay, so next we're going to talk about PEEP. And again, Tyler did an amazing talk at FAST on this. Since we have the LTV, we don't have the luxury of the fancy graphics and waveforms. So for most patients, it really is just set it at 5 and forget it, unless there's some sort of oxygenation issue we need to address. But I just want to pick your brain a little more on a few presentations, and you and Tyler have talked about this before on another podcast, particularly with the obstructive approach patients. So Tyler differentiates between asthma and emphysema in the obstructive approach, which I'd add the chronic bronchitis, which we would refer to as the blue bloaters, add them to that asthma group and just call them kind of the high resistance category with the bronchoconstriction and airway inflammation. And then have the emphysema group with the poor elastants. Those are the pink puffers. And I like Tyler's analogy to a plastic grocery bag that alveoli, which we pay 10 cents for here in California. You guys paying 10 cents for grocery bags over there?
No, and we don't, by the way, we can't take cans back. We don't get a deposit on cans. Yeah.
Oh, really? You guys are hurting us here.
I'm telling you.
We care about the environment out here. 10 cents for a grocery bag.
Wow.
Anyway. I'll just wrap it up. What I'll do is I'll take sorry, it's a tangent. I'll take the produce bags, that you can put your lettuce in or something, and just take a couple of those and shove those full of whatever else I'm getting there. So, 10 cents. I'm not paying it. It's principal. Anyway, so back to the topic at hand here. how do we determine optimal PEEP for these subset of patients who may have the auto PEEP? And I know you've talked about the waterfowl analogy, the 75-85% rule. Is that enough to manage both of these two different groups of the COPD emphysema versus the high resistance groups?
I think what we need to understand is the three classifications when we look at these obstructive lung patients. Number one, any patients that potentially could have auto PEEP are going to be classified as either a dynamic hyperinflation with an expiratory flow limitation. So that's going to be these patients that are considered chronic bronchitis, asthma, emphysema. Then we have patients that have that dynamic hyperinflation without an expiratory flow limitation. That's usually going to be based on an equipment problem. And I see that a lot. It's very easy to put a patient on the ventilator and not understand how to set your ID ratio or not understand the concept of time constant, giving them plenty of time to exhale. And then the last one is exaggerated expiratory activity without dynamic hyperinflation. That's essentially, do we have a spontaneous breathing patient that's actively exhaling, but that exhalation is not enough, and so you have an auto PEEP issue because of, do you have, asyncrasy going on? Do you have somebody in AC and you have a triggering problem based on our flow triggers? Things like that. So based on that, number one, we go back to standard teaching. I was taught, anybody obstructive lung pathway, 0 to 3 PEEP. I mean, Scott Weingart has taught that for years.
Right.
You talk to different respiratory therapists. I've talked to many different respiratory therapists, some of them that are nurses and some of them that are paramedics as well. You get some different thought processes, but for the most part, I feel like they agree with the whole waterfall effect. And I think it comes down to, the whole auto PEEP aspect is, number one, we have to be able to check that. We check that doing an expiratory hold on your ventilator. That's going to give you what their auto PEEP is. And the whole mindset of this waterfall effect is essentially reducing that opening pressure and kind of bringing that gradient closer together. And so the research paper that we are talking about, I did a podcast a few years ago on, and it was published by the Cleveland Clinic, and it's called Auto Positive End Expiratory Pressure Mechanisms and Treatment. And what they advocate for is essentially using PEEP to reduce that opening pressure and reduce the workload of breathing on these patients. And they use a 75 to 85% kind of rationale as to whatever their auto PEEP is, you're going to bring up the patient's external PEEP to that 75% level, and that's reducing that overall opening pressure. Do I think that we apply that the same with every patient? No, I don't. I think you have two different types of patients. I think you have that emphysema patient where, as you said, Tyler uses that elastin problem analogy where essentially you have a breakdown of surface area, you have collapse of those alveoli. Those alveoli are very, very brittle. Those are patients that probably would benefit from some PEEP. You have those chronic bronchitis patients that you have these thickened alveolar membranes, you have a lot of mucus production. Some may not benefit from PEEP. With those types of patients, you have some proximal airway inflammation, and so I think it's more important in those patients to stent open those airways. So I don't know if there's a right or wrong answer. Either way, I think you have to overall look at each patient and you have to evaluate what is my overall PIP and P-plat doing as I'm increasing my PEEP. If you're seeing those pressures maintain at or near what you started with, then I think adding more PEEP and more PEEP up to that 75% level may be beneficial. But if you're starting to see increases in that P-plat, and then that's probably not the right choice. Does that answer that question?
Yeah, well, it does. And I just wanted to kind of say how I think of PEEP in these different groups and see if I'm on the right track of it. So with the chronic bronchitis or the asthma ones with the airway inflammation and the thickened alveoli, if they have auto PEEP, it's because their alveoli are unable to get the air back out through the distal airways because of inflammation or collapse, critical airway or the distal airway collapse. So they're actually having auto PEEP that's helping stent open their alveoli. So the addition to PEEP for that isn't to help make that alveoli bigger or thinner or more efficient. It's more to open the distal airways, kind of to usher the air back out. And that's why we keep that 75 to 85% of the auto PEEP, so that there's like a gradient there, so the air has a place to flow out. Whereas in the emphysema patient, they may not necessarily have the airway, the distal airway problem. It's more of the alveolar problem, and the PEEP in that case is to stent it open and make it more efficient. And their auto PEEP comes from just the lack of ability to recoil and get the air back out. So is that on the right track for those two?
Yeah, absolutely perfect.
Okay. And then when you said you were initially a 0 to 3 in that kind of a thought process for these guys, does anybody in this category, do you think there's any benefit for 0 PEEP, or does anybody need Z? Like, thinking back on this now, and I just don't know that there's any patient that actually truly would benefit from 0 PEEP.
No, I agree. I think when you look at all patient subsets, I mean, the whole question of, do we truly have intrinsic PEEP? And I've had this conversation with Tyler, and do we have intrinsic PEEP? I mean, I think you have to look at the whole nitrogen that's left behind, and that does act as some type of pressure that's maintained in the alveoli that stents open those alveoli in normal physiology. I mean, that's the whole aspect and concept of what we call absorption atelectasis and giving high FiO2s. So there obviously is an impact of nitrogen that's left behind. So the point of that is that we have some type of intrinsic pressure that's maintained consistently based on that nitrogen.
It's not necessarily a PEEP. It's the same concept, but it's just there is volume, so therefore there's pressure that's keeping those open.
Yes.
So it's just not necessarily PEEP.
Right. So I think that concept of 0, I think you should always be, I don't know if I've ever started anybody less than 5. I mean, maybe little kids, little itty bitty immature lungs, I'd be a little bit more careful. But that would also be dependent on what's going on with those lungs. But I think 5 of PEEP is where I'm going to start my patients and then evaluate what's going on. And getting into PEEP and the impact of PEEP, you can do what's called a recruitment maneuver and evaluate how much PEEP can we apply that's going to optimize overall compliance. And so what you can do is you check a plateau pressure, you evaluate what that is, and we did a podcast on this last year. Mm-hmm. What's my plateau pressure? What's my static compliance? Increase my PEEP. Give a couple minutes, recheck my plateau pressure. If my plateau pressure has gone up, but it's not exceeding 30, and my static compliance has improved, then I'm going to go up higher. Again, let's say we go up now. Let's say we're at 12 of PEEP, for example. And prior to that, we were at 10 of PEEP. We had a positive changing static compliance. Our P-plats had not exceeded 30, but when we now increase it to 12, we check our P-plat. Our P-plat now is still less than 30, but our static compliance has actually dropped. So that is a recruitment maneuver, essentially saying 10 was perfect, 12 is too much. We actually had a reduction in compliance based on that 2 centimeter increase in overall PEEP. So that's a great way of always using the most optimal amount of PEEP in your patient to where you're not actually seeing a reduction in compliance, but an improvement in compliance.
How are you checking those plateau pressures since you're in pressure controlled ventilation?
That's funny, guy. That's funny. But that is a good point, that we have to understand that once we're actually moved, if you do decide to move from volume to pressure, once you're in pressure, there's never a reason to switch back to volume to check a plateau pressure, because whatever your inspiratory pressure, or we'll just say your PIP is, so your inspiratory pressure plus your PEEP, all these ventilators are additive now, so they're PEEP compensated. Whatever that is, we know that is the highest pressure that your alveoli are seeing. So there's never a reason to check that.
All right. Just some logistics on the expiratory hold. How long are you holding that for to get your auto PEEP?
On that, that's not so much a length. I just hold that until my auto peep comes up. It's not going to come up until you hold it long enough. When we do an inspiratory hold to check a plateau pressure, that's a very quick half-second hold, and I always tell students, essentially, when you see the number populate plateau pressure, you need to be pulling your finger off, and your mind cannot tell you to pull that finger off fast enough. Half-second hold is all you need. If you continue to hold it, it will drop that pressure down. It's not going to be accurate.
And then how do you determine auto peep in spontaneously breathing patients that you can't get an expiratory hold on? Because they can't be breathing spontaneously to get an expiratory hold, or they'll cut it off. So how do you determine it then?
Well, you can't. So in those patients, I mean, we have to go back to think about these types of patients. If that's one patient that I would say that you would maybe even consider paralyzing, it would be a severe obstructive lung patient. If you're having to worry about getting auto peeps on a patient, to me, that's a patient that needs to be extremely well sedated to the point of maybe even long-acting paralysis. And that's getting into the whole debate. Have we RSI'd them? If we have RSI'd them, are we using ROC, which the majority of the industry is now? So then they now have a paralytic that's 20 to 30 minute half-life. So they're probably already paralyzed to a point. But any of those patients need to be very, very well sedated or paralyzed in those cases. And the same thing goes with plateau pressure, right? If they're spontaneously breathing, 10 breaths over the vent, it's going to be very difficult to check plateau pressure in those patients as well.
Yeah, and I just think it's important to remember with this whole talk is that most of these obstructive patients are going to have a degree of auto peep. So it's not necessarily the auto peep we're worried about. It's it getting worse, us contributing to it to the point where we get that dynamic hyperinflation and start seeing some changes with our hemodynamics.
Yeah, correct.
Yeah. Just real quick back to the volume pressure thing with the plateau pressures. You do talk a lot about in your book, and when I've talked to you at the courses, trending that P-plat in patients with some sort of injury, blunt trauma to the chest or otherwise, being able to diagnose a pneumothorax or tensioning in flight. Is that a patient that you'd recommend keeping in volume so that you can kind of trend the P-plat versus the PIP? Because there's so many reasons the PIP could shoot up in a flight. Being able to determine if the P-plat's going with it, I would think would be important.
Yeah, absolutely. I think that's a really, really good point that you bring up. If you have a patient, number one, a multi-systems trauma patient, I talk about this with the review course. Really, if you haven't started flying yet, what you're going to realize is that your assessment ability in that aircraft is very, very limited in a lot of ways, and you're really relying on a lot of your equipment, where when we were all taught, you probably were taught in the whole language of don't treat your monitor, don't treat your equipment, treat your patient. Well, when you get into the critical care side and now you're in an aircraft, that kind of goes away. You have to understand your equipment and utilize your equipment to your advantage. And so if you have a patient that you identify, hey, they've got a simple pneumo, that would definitely be a patient that I would keep in volume to where I could trend those plateau pressures. If you immediately put them on the ventilator and you start identifying, hey, I've got high P-plats, I'm going to decompress that chest based on that. Or, if you're using chest tubes or you're doing finger thoracotomies, whatever you're doing, I definitely would want to continue to trend that. Absolutely. That would be a patient I would, it kind of goes back to, it kind of contradicts a little bit of why we would use pressure, because we're using pressure for a injured lung. We're using pressure to prevent barotrauma, but we're so limited in the transport environment, especially in a helicopter, to evaluate chest compliance. And the only way to truly do that is putting them on a ventilator and evaluating that P-plat. So that's definitely something that you would look at. Now, when you guys go to the Hamilton, the thing with the Hamilton is because it's a pressure ventilator, it has a calculated P-plat, but all a calculated P-plat is the PIP. That's all it is. And to get the P-plat calculated to show up on the Hamilton, you have to actually turn the inspiratory flow all the way down to zero to even evaluate that. So, there's in that patient, what I would do is I would basically evaluate if my P-plat or if my PIP was greater than 30, and then you'd have to make a determination. What are we going to do? Are we going to decompress off that, or let's say it's right at 30 and then it suddenly spikes up? Well, we know that PIP is always the highest of the two pressures. kind of put two and two together and say, hey, they've got mechanism, they've got kinetics, they've got the other injuries. We're going to decompress the chest. They had a simple pneumo prior. So a lot of that is kind of playing a guessing game, but it's always the best option to decompress those chests. It's never, ever smart to say,
well, sorry to jump back to the first topic there, but you said something that reminded me of it. So, okay, so the next couple questions are going to be specifically regarding the pressure control ventilation, since we'll try to be using that more since you're making us. We routinely use SIMV, like I said, usually in the volume control, but occasionally with pressure, and maybe we'll be doing pressure more now. I understand that in SIMV, the flow termination and the time termination are active for the spontaneous pressure supported breaths. But if we use pressure control, is there ever time we should be turning that pressure control flow termination on? And if so, when and why? And for those of you that don't know the LTV, in the back door, you can change this setting called pressure control flow termination. It defaults as off, and we have the ability to turn it on. I've never turned it on, and I just know it's there, and just curious if you've used it or when we should, if at all.
Yeah, so let's talk about number one, what flow termination is. So flow termination is applied and turned on. It's defaulted on the ventilators at 25%. And I'm talking about CareFusion, the LTV 1200, Ravel, and that flow termination defaults at 25%. So essentially what that is that's only applied to a spontaneously breathing or spontaneously generated breath when pressure support is obviously active. And so we know pressure support is active only in a spontaneous breathing patient when they take a spontaneous breath in SIMV only. So if you're in assist control, pressure support is not active, and you can see that function or that light is not active at that time. So flow termination is a way to control how to terminate that breath in that spontaneously breathing patient. So when they generate that breath based on that flow or pressure trigger, the ventilator has to know, hey, we need to terminate this at a certain point. And so essentially the way that works is, let's say they generate 100 liters of flow, inspiratory flow. It's going to terminate that at the point of 25%. So essentially 75% of that overall flow will be allowed, and then at the 75%, 25% left over, it's going to terminate that breath, and that's where exhalation then starts. So your question is based on pressure control flow termination. That is something that I've never used. I've asked and asked different respiratory therapists, and again, we got to be very careful because every ventilator is a little different. Every ventilator has different functionality, has different terminology. I mean, the concepts may be the same in some cases, but what we're talking about is pressure control flow termination in the Ravel LTV 1200 model ventilators. And essentially, when you turn that on in these ventilators, what it does is it completely takes over. So at this point, the pressure control flow termination is now in full control, and the flow termination for pressure supported breaths is now driven off of the flow termination, the pressure control flow termination, I should say. So the patients cannot control their breath now. And this is used in these ARDS patients that are having some major ventilator asynchrasy problems, or infants that can't sync to the vent, and that really have this need to have these spontaneous or higher spontaneous breathing patients on these ventilators. And so it's a more complex way of dealing with these patients. And again, I've never ever used this. I've never even thought to use this. It's essentially for these patients that need to flow cycle every single breath. That's how you would apply it.
Yeah. Okay. So where I have used it is using NPPV on the LTV. Do you think changing the 10 to 40% back to the SIMV patient for those spontaneous breaths, and I'm not talking about pressure control flow termination, I'm talking about the regular flow term for just your pressure supported breaths in SIMV. Do you think those breaths, I don't want to say matter enough, but are influential enough to need to change those? Are you changing those for those spontaneous breaths often, or are you just kind of leaving with that default 25?
Yeah, so that's where you get into, the whole aspects of, well, SIMV, get into the whole assist control SIMV debate. And I think it's really, really important, and it's so funny to hear these debates, and you hear it a lot from the nursing side, and I think it's not that they're doing anything or saying anything wrong. They're a product of what they've been taught or what they've seen in the ICUs. I think when you look at both of these modes of ventilation, we have to understand the underlying foundation of those modes are exactly the same. They both will guarantee a tidal volume and a rate every single minute, so it guarantees a minute ventilation. Where we see the application difference is in the transport environment. Our ventilators are primary flow triggered. It's very, very easy to, as you know, have a auto triggering event. Not every patient can be in a flow trigger. Not every patient can be in a pressure trigger. I think it's always safest to turn your ventilator to a pressure trigger in the transport environment. But if you don't know how to do that, or if you haven't been taught that and you're in that primary flow trigger, that's where we get into some trouble. And so we know the SIMV protects us from having those auto-triggering events. Basically, it says that every first trigger breath of a respiratory cycle is going to be assisted at that mandatory tidal volume. If the patient was completely sedated, they weren't actually spontaneously breathing whatsoever, but this was an auto-triggering event, you're not going to have any flow or generated breaths by that patient, and so there's not going to be any auto-triggering event. Whereas in assist control, every time that happens, right, we're obviously going to see a breath at that mandatory tidal volume given. So kind of coming back to that, when you look at pressure support we know reduces the dead space and reduces that workload of breathing on the patient when they take that spontaneous breath. We can automatically allow our patients to do too much work, and the best way to approach that is to say we never want their spontaneous tidal volume to exceed 75% of their mandatory tidal volume. So if we had a 400 tidal volume set on the ventilator mandatory, we would never want their spontaneous breath to exceed 300. We can control that in some different ways. We could give them more sedation, which is obviously a very simple way to deal with that, more pain management. But we could also turn the pressure support down, which, if we think about it, that actually increases the workload. So it's going to make the patient have to work a little harder. That may not be the best approach. We could also turn the sensitivity up higher. That's also going to make them have to generate more on their spontaneous breath. But another way to deal with that is to, just based on your question, well, could I turn my flow termination up or down? Well, we know that it's the area under the curve. So imagine just for simple purposes, just this bell curve. It's the area under that curve that dictates the overall volume. So if we terminate that breath, as I said, it defaults at 25%. Well, what if we terminated that breath earlier at 40%? So if they were generating 100 liters of overall flow, we essentially terminated that at 40% left over, so they generate 60, we terminate it. The area under that curve is actually going to be smaller, so we're actually limiting their volume.
Less volume.
And so that would be definitely a way we could help reduce overwork. If we identified, hey, their spontaneous tidal volume is too high, we're getting way too much, that would definitely be a way to do that. Or what if they're not generating enough? What if we wanted to give them a little bit more ability? You could actually turn that flow termination down to 10%. And that would actually give you more area under the curve. And you see, so that's a way we can kind of guide their overall ability to take that spontaneous breath in ways that aren't going to truly increase or decrease, or I should say increase, the workload of breathing and that be counterproductive. Does that answer?
Okay. Yeah, gotcha. Yeah, because I always thought that when you said, give 75% of the volume you want, that does seem counterintuitive to go down on their pressure support, that they're going to end up working more. But I like that idea of using the flow term to help you get your volumes where they should be so they're not overworking without having to go down on the pressure support. I just wanted to say something that might be helpful to people who are very, very new to mechanical ventilation, and they hear you say flow a lot, and you're talking 100 liters per minute. That took me a while, again, because I'm a simple nurse. SICU nurses bring a lot of problems to transport. but that's not how much volume they're getting. It's a rate, like you're going 60 miles an hour doesn't mean you're going 60 miles. You're going 60 miles an hour. You're not giving 100 liters per minute. It's a flow rate.
Correct.
And that's not like a question for you. It's just throwing it out there for people who are really new. And that was a hard concept for me to understand, which goes back to when you say upping the sensitivity, making it, for these flow triggering. If we're at 3 liters per minute of a sensitivity and we go up to 5 liters per minute, that doesn't mean they have to generate 5 liters per minute. It's a flow rate, not, you know what I mean? Like,
yeah.
It's not a volume, it's a rate.
Yeah, so it's a per minute thing, but you would always divide that to get an idea of what that was per second. So you divide that. Let's say they had a inspiratory flow of 40 liters a minute. You could divide that by, well, let's just do easy math. Inspiratory flow of 30 liters a minute. We divide that by 60 seconds. That gives you basically a 0.5 ratio per second. So same thing with what you just said. Sensitivity of 3 on a flow trigger is actually going to be 50 mils a second. That's how much flow they have to change to trigger that breath. You turn that up to 5. That's 5 liters a minute of flow. And that's you divide that into 60 seconds, and that's basically going to be 83 mils a second of overall flow needed. So the higher we turn the sensitivity up, and we're using 2 different kind of thought processes there, but it's exactly the same concept. It's just used in different ways.
And that doesn't mean they have to move 83 mils in a second. It just, as a fixed number, they can move whatever 41.5 mmls in half a second, right? It's just they have to move that volume at that speed to make it generate. It's not a fixed, you have to do 83 mLs in 1 second. You know what I mean? Like, does that make sense?
Yeah.
Okay.
Absolutely.
It's like I have to drive 60 miles an hour for 30 minutes to go 30 miles. It's not, you don't have to go 60 miles to go 60 miles an hour.
Right.
Correct?
Yeah, and it doesn't take the patient having to do that. You could just shake the circuit and change that flow.
Yeah, exactly.
That amount. And that's where that flow triggering is so sensitive, and that's where we get into some trouble.
Yeah. Okay. Well, moving on to another topic here that applies to pressure control only. And I know you've done a whole podcast on this, but I just still have some questions I want to clear up in my mind. And basically that's the concept of rise time. And I'm not sure how other vents work, but with the LTV, we have 9 profiles, with 1 being the fastest rise time and 9 being the slowest. In your book, you say to use a faster rise times, which would be in the 1 to 4 range for patients with high PIPs, hypoxia, and air hunger, as an example. And then to use slower rise times in the 5 to 9 range for bronchospasm, pressure overshoot, shunt problems like ARDS, and then small ET tube. But just thinking through those, it seems like the high PIPs that you have in the 1 to 4 range should be included in the slower 5 to 9 range, because a lot of those reasons in that 5 to 9 range seem to be able to cause high PIP. So just help me and the listeners kind of think through using rise time a little bit more to our advantage. Again, because this is pretty much all I've used this for is for NPPV to make the BiPAP more comfortable. So how could I use this in PCV to my advantage and our patients' advantage?
So I think that rise time, we have to understand kind of the application of rise time. Rise time is only applied, number one, in pressure control ventilation. It's not applied in volume. So when we're in volume, we're directly driving how that breath is delivered based on your inspiratory time. But we're in pressure, we have what's called rise time. We still have the inspiratory time set, but within that inspiratory time, we have to be able to deliver that breath, and we can deliver our breath maybe very steeply. That's going to be a fast rise time, or very, very slowly. So think of a slow, gradual hill. And that's, in some ventilators, looked at as ramp. So a very fast rise time profile, a profile of 1 is basically a tenth of a second, all the way to a profile of 9 is going to be 1 second. Now again, we're talking about CareFusion, we're talking about LTV 1200 and Ravel. The Impact, the Envy, there's no rise time profiles. Some ventilators may have ramp. The Draeger has ramp. When we look at like the Hamilton actually has a bigger range. I think it goes up to a rise time profile of 18. So there's a big difference as far as what different ventilators are going to be able to do.
Yeah.
But essentially, with the Care Fusion models, a profile of 1, as I said, is 1/10 of a second, all the way to a profile of 9 is going to be 1 second. And it's essentially how fast or how slow is that breath delivered. Again, it's got to happen in that inspiratory time. So we use an application of it defaults at 4. When would we want to use a slower rise time? So think back at these patients that have a high airway resistance. So that's where I'm kind of rethinking the terminology of a fast rise time with high PIPs. That's not truly what I was trying to say. I was trying to say more a hypoxic, air-starved patient. That's where you're going to want to set that rise time profile at lower number to where that breath is delivered very rapidly. And Care Fusion actually recommends that in non-invasive positive pressure ventilation. So BiPAP is to always default and go right into your rise time. Turn that down to 1. They want that breath right now. Versus if you have somebody with a lot of resistance, you want to be able to deliver that breath kind of more gradually. And that goes back to that analogy I used with the balloon with a stir straw. Mm-hmm. If we don't have enough time to fill, we're not going to ever get any volume. So that's where any pediatrics, right? Any small ET tubes, any bronchoconstriction or spasms, anything like that, you're going to want to use a slower rise time. So you could go from 5 to 9. When we look at this overall, though, what I've found is that these are just very simple variations where every patient is going to be a little different. And you almost have to just play with the ventilator with these rise time profiles. I mean, this will give you a guide to say, hey, I'm going to start on the higher end for these, airway constriction type patients. I'm going to start on the low end on these patients that want that breath right now. But again, these are just guides to where you have to then fine tune the ventilator to the patient.
So yeah, that makes sense. So shutting or doing a faster delivery of the flow is going to make you, if you're through somebody with bronchoconstriction, say, or a pediatric, you're going to hit your peak pressure faster, so you'll have less volume delivered. Is that what you're saying then? It's like, for instance, if I have a funnel and I turn the faucet on max, more flow, it's going to overflow, trickle it in, the flow slower. I can get more volume of water through that funnel before it overflows. Is that a good analogy for thinking of that?
That is correct. With that being said, though, we have to have enough time. So another example of where we have to really watch is on these little neonates, pediatrics, right? What's their standard ID ratio? Well, ID ratio on these little guys is a 1:3, but we don't utilize that concept or that terminology. We use an I time, and we use I time of 0.3 to 0.7 in that range. Mm-hmm. So let's say we have a little itty bitty neonate, and we have a inspiratory time of 0.3 seconds. Well, if we go back to what we just said, any small ET tubes, we would want a longer rise time. So what we have to understand is that if that rise time is super, super long, but our inspiratory time is only 0.3, basically you're never going to get that full breath delivered, because if that ramp is so gradual, that inspiratory time is going to terminate at that basically 0.3 of a second. And if your rise time was 9, or 1 second, do you see the problem?
Yeah.
Is you're not going to get that full breath, and so that's where you're going to have a big problem. And we have so the point is that we have to make sure that we understand, can my rise time fit into my inspiratory time?
Gotcha. Yeah, in your book, you do say, they're 1/10 of a second is profile 1, 2/10 of a second profile 2, and so on. You also say they're 3% longer than the one before it. So my question is the profiles fixed off of a 1 second time, or is it based off of, say, if my inspiratory time is half a second, then does only profiles 1 through 5 apply, or does it actually take that 1 through 9 and make them, 1/10 of the half a second, for profile 1, 2/10 of half a second for profile 2, and all the way up to 9/10 of half a second? Or is it fixed off of a 1 second? That question makes sense?
No, it's fixed off of 1 second.
Okay.
Yeah, it's fixed off 1 second.
Okay. was gonna say it wouldn't make sense to use a profile number higher than, the decimal of seconds of inspiratory time, like you were just saying about the PEED.
Yeah. So for an example, I mean, if you had an inspiratory time of 0.3, rise time profile of 5 is going to deliver that breath in basically, a little over 0.3 of a second. So that would be the highest you would want to go with that little guy like that. And when we say 33%, you have to look at this from the perspective of these numbers are in hundredths. So, that's where you gain the 33%.
Cool. Yeah. Anything else
Yeah.
you wanted to add to the rise time? We'll move on to the last topic here.
No.
This is a quick and easy one. You talked a little bit about PEDS earlier with the vent circuit and pressure, but haven't seen a whole lot, whether in your book or in podcasts, about mechanical ventilation in pediatrics. So if you could just touch, briefly on general strategy, you could do a whole podcast on this for easily, but just general strategy, how you determine ideal body weight, determine respiratory rate. Are you still using the same 68 AMLs per kilo? I imagine you can't use that 100 mLs per kilo per minute for determining minute ventilation. So just kind of all that, where you start and how you get to determining what your starting settings are going to be.
Yeah. I think with kids, number one is you're always going to want to use your weight-based guide. I think I think the hand-Tavy system is obviously the best out there. I think it definitely has revolutionized the way we look at every aspect of resuscitation in these kids. And so everything needs to be based on their weight and age, right? So we look at their age and get an estimate on their overall weight based on ideal body weight for that overall age. And then we are going to still use the 6 to 8 mils per kilo. Respiratory rates are going to be based on their age. So I mean, if you have a standard, neonate is going to be anywhere from 40 to 60 breaths per minute in some cases. A standard 5-year-old, I'm going to probably set my rate between 20 and 24. So we got to get some type of what's standard for their age, and then look at their overall disease process. Yep. And if they're in a severe metabolic acidosis, we may have to increase that, etc. The obstructive lung pathway, we talk about the whole obstructive approach of lowering that rate. Again, we're only going to lower that rate a little bit. We're not going to take them all the way down to 10 to 12 breaths per minute. If their standard rate is 24, I might bring it down to 18, see how they do. If, can we gain any more by lengthening their exhalation time? So that's where we're going to calculate their time constant and go through that whole aspect of looking at the resistance and divide that by that flow and, get that number. So my respiratory rate is going to be based on their age. The overall 100 mils per kilo per minute of minute ventilation doesn't really work for kids. As long as you're going 6 to 8 mils per kilo and using a rate that's adequate for their age, and then understanding the whole aspect of mechanical dead space, the whole volume versus pressure debate, and that's where I'm going to start.
Luckily we have end tidals and blood gases, and you can go from there. Well, cool. Yeah.
I think the biggest thing I've seen with kids in mechanical ventilation is it's very, very hard to keep them sedated. And so they really need to be on SIMV. You look at these NICU teams, you just don't paralyze these little guys. And so it's all right to let them overbreathe. They have a very fast intrinsic rate. Let them contribute. I think the one case where you would want to maybe limit that is in these really sick, obstructive, maybe an asthmatic or somebody like that. But, let them help. And I've seen that over and over where you just can't give them enough medications. They burn through it so fast. So you're going to definitely want to allow them to contribute to that overall minute ventilation.
Well, cool. This has been fun. It definitely more challenging than the days of, at least when I started, 5 milligrams of Versed and 10 of Vec, AC 500, rate of 12. That was easy and definitely. But this has definitely made a huge difference. Having you out and reading your book. I can't tell you the last time I paralyzed somebody outside of RSI. So, and you've definitely helped us make our patients more comfortable, and I'm sure contributing to better outcomes as we deliver our patients. We definitely see that as we deliver them now with these settings and the concepts you taught us, that wherever we're taking match our settings more frequently. So it's kind of cool to see that and to know that we're, contributing to their overall ICU stay as well. So pretty sweet. Yeah.
Yeah, that's really cool. And I just want to say to the listeners, a lot of this is, it's an evolutionary process. I mean, I'm constantly still learning and constantly trying to, broaden my perspectives. A lot of this is troubleshooting, and every patient is going to be a little different. And, you got to start with the foundation. And the foundation is become comfortable with the ventilator, pull it out every shift. I can't stress how important that is. We have a lot of recliner time. We have a lot of, downtime at the base. And, shame on you if you're, and I'm saying that as nice as I can, if you're not pulling your equipment out every single shift and playing with it, then, you're really doing yourself a disservice. It's so hilarious. I talk about Tyler a lot, but he'll send me pictures, and he's obsessive about things. But I think every single shift he was on for the first 2 months, he was ultrasounding himself. He'd lay down on the dolly on the aircraft and he'd ultrasound himself. I mean,
he takes nerd to a level I don't think I'll ever be able to.
But you have to be that way. You really truly have to be that way. And I'm very, very much that way as well. I was the same way with a ventilator. When I realized I didn't know and didn't understand, I don't like that feeling. Yeah. And I'm not comfortable with just having a real surface understanding of things. I want to be able to not fumble.
Right.
And so I think we really have to take it upon ourselves to surround ourselves with somebody that can teach you, make sure that you understand what they're teaching, and don't be afraid to ask questions. Don't be afraid to, have that double check. And it's a constant learning process. So hopefully this podcast, we hit on 5 topics, was beneficial. Apologize for just the banter back and forth, but I think that brings some simplicity to the podcast. That all this was off the cuff, and hopefully it was beneficial. And if you do have any questions, please again email me at eric.bauer@FlightBridgeED.com, and probably gonna do a follow-up podcast and maybe do some other topics. And on behalf of everybody at FlightBridgeED, again, I want to thank you for joining us, and we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.